Hello, my name is Jim Pender, and I am a community health consultant with the Iowa Department of Public Health. I serve as the grant manager for the Administration for Community Living's Traumatic Brain Injury State Partnership Program. Iowa is one of 28 states that receives funding from ACL, and I would like to share that Iowa is the only state that has been continuously funded through ACL since 1997. Today, June Klein-Bacon, who is Special Projects Manager at the Brain Injury Alliance of Iowa, and are pleased to be able to share information with you about the intersection between brain injury and behavioral health. Next slide. Just a few disclosures we should mention before we get started. The development of this presentation has been supported by the Brain Injury Services Program at the Iowa Department of Public Health and a contract with the Administration for Community Living. We will be highlighting the pediatric lifetime history of brain injury and other traumatic brain injury and other acquired brain injuries screening tool, which is adapted from the work of Dr. Pat Sample of Colorado State University and the OSU TBID and other acquired brain injuries adapted from Dr. John Corrigan at the Ohio State University. Both of these screening tools were developed with the support of the Advisory Council on Brain Injuries. And finally, the content of this presentation is not intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician and/or other qualified health providers with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay it, seeking it because of something you have heard in this presentation. Next slide. During this session, we will review some basic information about brain injury, including incidence and prevalence data. In addition, we will review Iowa's pediatric and adult screening tools. And finally, you will also learn about the supports and services available for individuals experiencing brain injury. And with that, I'll turn it over to June.
Thank you very much, Jim. Sharing with you at our 30th annual conference, we do not take for granted that many of you have heard some of these concepts before or are very familiar with these concepts. But these, for those of you that are attending that may be first-time attendees or new to the arena of brain injury supports and services, we do want to cover some basic information. So we'll just start with some basic definitions here. Acquired brain injury, or ABI, is an umbrella term that encompasses both non-traumatic brain injury and traumatic brain injury. Momentarily, we're going to look at an additional list that includes a variety of types of brain injury that are recognized here in Iowa. Oh, having a few issues with my slides there, so sorry about that. And so we're going to be looking in a few moments at the definitions of brain injury here in Iowa. When we look at this broad definition, when we think about non-traumatic injuries, we might be thinking about internal insults to the brain, such as stroke, poisonings, infections. Traumatic brain injury, or TBI, which is in this umbrella term of acquired brain injury, is what many people often think of when they think of brain injury. TBIs are caused by an external force. This can include penetrating and non-penetrating injuries. And in addition, I do like to make sure that folks hear that concussions do fall under the definition of mild traumatic brain injury. So while not all, and frankly, most brain injuries do not lead to a long-term disability or the level of needing and requiring home and community-based services here in Iowa, this serves as a nice reference from Iowa Administrative Code, providing definitions of brain injury related to the mechanism. And then, of course, when we think about these services, we're looking at the impairment to physical, cognitive, and behavioral functions. And so you can see here that there are a variety of causes listed. Not all of them are listed here on the screen, but they can be found in administrative code. Because of the various mechanisms of brain injury, there are times that people may not identify that they have a brain injury. In fact, we know that over 40% of individuals that sustain brain injury do not report that they didn't get medical attention. Because of this, it is critical for us to hear the language that people are using around possible brain injury. There are many factors, of course, that play in the role of accessing medical attention, as well as in the recovery process, that are going to include pre-brain injury or pre-injury status, post-injury response, efforts made in rehabilitation, as well as a variety of biopsychosocial and economic factors. And we also want to add that there is also something to be considered related to the cumulative effect of brain injury. For example, having multiple concussions. Some considerations related to under-recognized relationships to pediatric brain injury. We have some slides here that we are going to show some coming up that are going to be showing some of the timeframes that mechanisms of brain injury are happening here in Iowa. In thinking specifically about the experiences of youth or the adults that we might be serving, there are some stats here to consider. 18% of all traumatic brain injury related emergency room department visits involve children under the age of 4. And when we look at mechanisms of pediatric injury, almost 50% of TBIs in young children are related to assault, child abuse, and falls. We also can point to studies that indicate that 2/3 of children under the age of 3 that have been physically abused have also sustained a traumatic brain injury. Understanding some of those brief stats can really help us think about the questions we ask when we're doing social history with our clients, gathering information about their history. I would encourage you to note that particularly those that are providing mental health services, that individuals with post-concussive syndrome are at a higher risk for developing anxiety disorders as well as depressive disorders. And while we cannot cover all the nuances of pediatric injury in these couple of slides, we do want to just point to a few things that may be helpful as you think about lifetime history of brain injury. When we consider brain development, it's worth noting that the brain doesn't fully develop until we're in our early to mid-20s. And considering this, when we think about pediatric injuries that have occurred, full effects of brain injury may not appear until later in life. You may hear that youth grow into their brain injury. And so when we think about things like developmental stages, this can come into play when we think about the onset, the age of onset of their injury, and what facets of their injury may not be fully known or recognized until they age into their 20s. The age of onset, of course, also impacts the ability to draw on capacity and skills, as well as life experiences in terms of strategy development as they age. So if a youth has not reached that developmental stage at the time of injury, this may impact their ability to draw on those functions. I do want to talk a little bit about Iowans. Here in Iowa, there are approximately 3,100 Iowans that are hospitalized on an annual basis as a result of brain injury, and approximately 100,000 Iowans that are living with disability as a result of brain injury. We know in comparison, when you're hearing that number, 100,000 Iowans living with disability as a result of acquired brain injury, we know that just between 15 and 1,600 people are accessing that home and community-based brain injury waiver here in Iowa. So we certainly recognize that people are being served in other systems that have brain injury. These next couple slides, I think that are interesting, particularly when we think about gathering those lifetime histories, thinking about pediatric injury, for example. This slide gives us some information related to the annual rates of traumatic brain injury emergency room visits by age and by mechanism of injury. So drawing your attention back to some of the comments that I made about pediatric injury, I would call your attention to the spikes that occur in the blue line that are occurring here between the ages of 1 and 4. We have a spike in falls. And then in the ages ranges of 5 to 14, you can also see in the orange line where we have a spike here with being struck by or against. We also have spikes in our teen years and early 20s with assaults as well as motor vehicle crashes. So you can see those spikes here. We also just for your notation, we see another spike in our aging community when it comes to falls later in life. Now, this slide is about emergency room department visits. In this next slide, we can see the rates of hospitalization by age and mechanism. And you can see that hospitalization rates are actually much lower, with spikes occurring as a result of motor vehicle crashes, and then another spike with our aging community with falls again. So just to kind of think about that, we have lots of folks, again, that are not accessing the medical communities, but that gives us some information on who might be accessing medical care at what ages and stages of life and the mechanism of injury. And as we continue to learn more about brain injury and also multi-occurring conditions, we continue to understand that brain injury, as with most health conditions, don't live in a vacuum, right? So often research and studies are pointing us to understand that brain injury occurs frequently in other populations that are being served in other systems. You can see here a variety of populations or groups that access services or systems that are beginning to recognize the higher average brain injury rates that may be occurring when they're getting access to supports and services or touch points within these other systems or life experiences. So while I've laid out just a few brief variety of stats here for you, hopefully a picture is being painted to lead us down a path to understand that either undiagnosed or under-recognized brain injury in other systems may impact individuals' abilities to thrive, to live and contribute to their own communities and families, or even be successful with treatment plans or service plans long-term. Undiagnosed and untreated brain injuries can often result in mislabeling or missed opportunities to address underlying cognitive, neurobehavioral, or even physical implications of brain injury that could impact a person's well-being, health, and safety. So this slide gives you a nice visual to remind us that the brain is responsible for really every function when we think about cognitive, physical, and emotional and behavioral functions. It gives us some understanding of the structures of the brain and may give us some insight when we are able to learn the points of injury that somebody may be experiencing where they might be having some challenges, but also may even point to some strengths that somebody might have. With permission from Co-Kids in Colorado, we do have a few slides that give a really nice visual in terms of thinking about brain development and also understanding the building blocks we need in place for various processes and overall functioning. Again, reverting back to thinking about the development of our brain, we then are able to start to visualize how these different functions in this pyramid here contribute to each other and how our brain is truly interconnected and how those functions are interconnected. With injury, while it's certainly more complex than this, if we remove or impact just one function, we can begin to see the impact it can have on other functions, or when we ask somebody to engage in a higher order function, we see the collapse of the integrity of those functions, right? So, and while we have expectations for people in our life that do not have a perfectly formed pyramid per se, related to brain function, the ability to reach higher order thinking, people are going to fall short of our expectations. So when we're able to start thinking about how to respond to functional loss, it is critical that we start to understand that loss of function is not a matter of choice when we are addressing those symptoms of brain injury, much like it is not a matter of choice that someone may require a mobility device for ambulation. I would like to point to this concept of brain injury as a chronic condition. In the medical model, we recognize brain injury as a chronic condition. We know that while the general population experiences brain injury at rates of 4 to 8%, we know that in other systems and in other life experiences, brain injury is much more prevalent. We know that individuals that experience homelessness, for example, are 5 times more likely to have sustained brain injury, with many of those occurring that the injuries happened prior to becoming homeless. 50% of individuals receiving substance use disorder treatment um, have had a prior brain injury. And there are studies that point to 72% of individuals in dual treatment programs for serious mental health and substance use disorders report that they've had at least one traumatic brain injury. And when we look at the criminal justice field, we know that 60 to 80% of adults have sustained brain injury prior to incarceration, and 44% of juveniles have sustained brain injuries that are involved with criminal justice or juvenile justice. And because we know that brain injury is often a multi-occurring condition, we do see it as best practice to respond with a brain injury screening, particularly in settings that are serving people in clinical or community-based settings related to health or access to the community or even criminal justice systems. I am going to turn it over to Jim now, again, to address the screening practices and tools that have been endorsed here in Iowa. And I'm looking forward to hearing more about the progress that Iowa has made with these screening tools.
Well, I was muted there, and it took me a minute to navigate back and forth between some screens. Thanks, June, very much. I appreciate it. Yes, June talked quite a lot about the importance of screening, but I wanted to just highlight a few other things. So why do we screen for brain injury? Well, there are identified programs required to complete brain injury screening within Iowa Administrative Code. So of course, that's very important. And second, there are lots of opportunities to consider brain injury screening in additional settings. And as June suggested, with proper screening, assessment, and evaluation, treatment, rehab, and their community-based supports are linked to strategies that include medically necessary accommodations and/or compensatory strategies. Now, depending on your relationship and the services you are providing, you may choose to consider completing a brain injury screen at a variety of times. It may be at the start or prior to the start of services, waiting till you've built a relationship with new clients or with existing clients, or when you see a significant physical, cognitive, emotional, or behavioral change. While screens are not diagnostic, they can support a person, a family, and his or her team to identify if additional referrals or more in-depth assessments are necessary and can support and inform service or treatment planning. Next slide. So let's take a look at the screening tool. This is the pediatric lifetime history of traumatic brain injury and other acquired brain injuries. And it asks you 3 primary questions to think about. The first question is to think about injuries a child has had during their entire lifetime, especially those affecting the head or neck that may have caused loss or alteration in consciousness. The second question is to evaluate if the child or the family has ever been told by a doctor or other health professional that they've had a number of conditions, for example, a tumor of the brain, a stroke, etc. And the third question is to evaluate if the child has ever been to the emergency department or received other medical care related to a brain injury. Next slide, please. So just wanted to share with you that you can administer the screening tool either by telephone or face-to-face. Complete questions 1 through 3 by reading the prompter statements that are in the with the black background and questions for each section, followed by each response option. While these are not included in the slide deck, there is an instructional sheet that we can send out to you later on if you have interest. And just wanted to make a point clear for not only this screening tool, but for the adult screening tool. to have some trauma-informed awareness or sensitivity that sometimes these questions can be triggering, and you want to be cognizant of that when you're administering the screening tool. Next slide. And again, this tool is not based on an elicitation of a perfect accounting of a person's lifetime history of brain injury. Instead, it provides a means to estimate the likelihood that consequences have resulted from one's lifetime exposure to brain injury. If any of the following are seen, you'll really want to consider further assessment. Next slide. Oh, yes, just wanted to mention if you see, concussion, a loss of consciousness, confusion or altered mental state, missed school, been sent to the ER, so on. If you're seeing those types of things, that's when you really want to consider further assessment. Thanks, June. Next slide. Now let's talk about the adult screening tool. Again, this is normed for uses for individuals aged 13 and up. Again, it's a reliable and valid instrument. And it's adapted from the Ohio State University Traumatic Brain Injury Identification Method and other acquired brain injuries. This screening tool asks 4 broad questions, and we'll look at it in just a minute, but it asks if an injury has ever caused a loss of consciousness, if an individual experienced repeated impacts to the head, if an individual ever lost consciousness from a drug overdose or being choked, and if an individual has ever been told by a doctor or health professional they have a number of conditions, again, for example, a tumor of the brain, a stroke, exposure to toxic substances, etc. Next slide. Here's a picture of the tool itself. It's available on our website. You can see the hyperlink there. It will soon be available to be completed by organizations on Your Life Iowa, coming very, very soon. If you have interest to be able to access that on Your Life Iowa, please email us after the presentation. Our contact information will be available at the end. And you can reach out to us. And again, just a reminder, especially questions around choking, maybe trauma in triggering, to be sensitive to that as you complete the screening tool. So let's look at these a little bit more closely here. This is the first question, and it wants to know if an injury caused a loss of consciousness. In addition, you'll want to know how long the individual was unconscious and at what age the first TBI occurred. Next slide. Questions 2, 3, and 4, they address any acquired brain injury combined with any other way brain function has been impaired. And question 4 addresses the diagnoses that are in Chapter 83 of the Iowa Administrative Code that potentially qualify someone for the brain injury waiver. Again, as with the pediatric screening tool, administering the screening tool either by telephone or face-to-face, you want to complete questions, reading the prompter statement for each section, followed by their response. And I'll just say again, while not included in the slide deck, we do have an instructional sheet we can send out to you that will help guide you in being able to fill this out. And again, just another reminder to be sure to be trauma sensitive in the completion of this screening tool. That's just a high level overview of that. Both either June or I are glad to speak with you at further length regarding this screening tool, how to complete it, how to access it, and how it may benefit your work with the individuals that you're serving. June, back to you.
Thanks, Jim. And again, Jim has mentioned it. Screening is not diagnostic. It does not give the person or family or team an opportunity, but it does give the team or person an opportunity to evaluate additional needs, whether assessments are necessary or further referrals are necessary. Some options to consider following a positive screening may be to refer to a physician for further assessment, informing the treatment or education team of the findings to begin thinking about how maybe differentiated instruction or accommodations or adjustments to a service plan or a treatment plan may need to be considered. Here in Iowa, you also have access to the ability to refer individuals or teams to the Brain Injury Alliance of Iowa for information to support navigating next steps. And for those folks, again, that are new to this conference, I do want to cover some brief information about our program at the Brain Injury Alliance of Iowa. I would encourage you to visit our virtual booth, our vendor booth, as well as I believe Iowa Department of Public Health also has is here as a vendor this week. The Brain Injury Alliance of Iowa's primary service line is neuro resource facilitation. It's an evidence-based practice and nationally recognized. This program is funded through the state legislature, and we contract, the Brain Injury Alliance of Iowa contracts with the Department of Public Health, making it accessible for all Iowans. This program is virtual or phone-based and available to individuals with brain injury or suspected brain injury if you've completed a positive screening. Uh, their family members or caregivers, their support system, as well as professional touch points that may have questions about brain injury and navigating next steps. Through this program, we also offer case consultation or technical assistance to support professionals and support teams to build the capacity of serving people with brain injury in their communities. We also have a unique opportunity for programs and professionals to apply to join our Iowa Brain Injury Resource Network. This network is truly designed to continue to build that capacity here in Iowa to serve Iowans. Network members have access to specialized training, educational opportunities to learn more about our services, in addition to potentially implementing brain injury screening, and what that might look like for your organization. In addition, through our Iowa Brain Injury Resource Network, we have the opportunity to share some hard copy resources for you to have on hand, for your staff to have on hand, as well as to be able to give to clients and patients that may screen positive for brain injury or in fact have a diagnosed brain injury. In addition, we do have a direct referral program that we've launched for our Iowa Brain Injury Resource Network members. And so as it makes sense, we can certainly talk about what a direct referral program for individuals that have brain injury or screen positive for brain injury might look like for you. So I would invite you again to visit our virtual booth, as well as if you have questions, as Jim's mentioned, he and I will have our contact information here at the end. You can also email info@biaiowa.org for additional information, and I will plan on dropping some links in the chat as we're moving forward as well. So I do have our contact information listed here on the screen for you all. We will be on live to be able to respond to questions and comments. And we can also drop our information into the chat as needed as well. And so with that, I would just like to say thank you for your time today in hearing this brief discussion about brain injury and brain injury screening and opportunities that we have in here in Iowa to support that effort. Thank you.